Hello and welcome to the Deep Microbiology channel. Today, I'm excited to begin a new series where we'll explore different topics related to stool health and gut function. In this first video, we'll be talking about a common issue, diarrhea. Let's jump into part 1, understanding diarrhea. Diarrhea. It is an increase in daily stool weight above 200 gram, with increased liquidity and frequency of more than 3 times per day. According to the American College of Gastroenterology guidelines, based on the symptoms and duration, diarrhea should be classified as 1. Acute diarrhea, symptoms of loose stools lasting up to 14 days. 2. Persistent diarrhea, symptoms last 14 to 30 days. 3. Chronic diarrhea, symptoms persisting over 30 days. Diarrhea is also classified based on the underlying pathophysiological mechanism, as follows. 1. Secretory diarrhea. 2. Osmotic diarrhea. 3. Exudative diarrhea. 4. Altered motility. And 5. Malabsorptive diarrhea. In secretory diarrhea, there is increased active secretion or inhibition of fluid absorption with little or no structural damage. This type of diarrhea continues even during fasting. A well-known etiologic agent for secretory diarrhea is enterotoxin-producing organisms like Escherichia coli, Clostridium, Vibrio cholerae, Salmonella, Shigella, Staphylococcus, Campylobacter, protozoa, and parasites such as Cryptosporidium can stimulate the sweater and electrolyte secretions. Other causes such as drugs and hormones, inflammatory bowel disease such as Crohn's disease, ulcerative colitis, lymphocytic colitis, diverticulitis, endocrine disorders, hyperthyroidism and so on, neoplasms and collagen vascular disease. Osmotic diarrhea, caused by non-absorbed substances in the intestine that draw water into the bowel, by osmosis. Stops with fasting, or when the offending food is removed. Causes. 1. Disaccharidase deficiency such as lactose intolerance. 2. Malabsorption such as celiac disease. 3. Poorly absorbed sugars such as lactose sorbitol mannitol. 4. Laxatives amoebiasis and antibiotic. Exudative diarrhea is due to inflammatory disease and characterized by purulent, bloody stool that continue during fasting. It is usually caused by bacterial, viral, or parasitic infections, but can also occur in patients with inflammatory bowel disease, tuberculosis, or colon cancer. Altered motility refers to abnormal movement or contractions of the muscles in the gastrointestinal tract. This can lead to changes in the speed or coordination of digestion, resulting in symptoms such as cramping, bloating, diarrhea, or constipation, as seen in conditions like irritable bowel syndrome. Malabsorptive diarrhea, caused by inadequate nutrient absorption, is associated with steatorrhea and is relieved by fasting. Steatorrhea. The definition of steatorrhea is an increase in fat, triglycerides, excretion in the stools, absence of bile salts that assist pancreatic lipase in the breakdown, and subsequent reabsorption of triglycerides, produces an increase in stool fat that exceeds 6 g per day. Steatorrhea is one of the clinical features of fat malabsorption. Causes of steatorrhea include 1. Pancreatic insufficiency leads to malabsorption. 2. Pancreatic disorders, including cystic fibrosis, chronic pancreatitis, and carcinoma, that decrease the production of pancreatic enzymes. 3. Small bowel disorders such as celiac disease, tropical sprue, and Crohn's disease. Screening for steatorrhea may be carried out by examining stool samples for the presence of fat using Sudan 3 staining, or by performing a D-xylose test on blood and urine. Sudan 3 staining is a microscopic test used to detect fat globules in stool samples. It can be performed using either direct or indirect methods, each offering insights into different aspects of fat digestion. When used together, These methods help distinguish between digestive disorders and fat malabsorption issues. Indirect method. Place 1 drop of fresh feces on a clean microscope slide. Add 1 drop of Sudan 3 stain to the feces, and mix them gently. Gently warm the slide until bubbling appears. This facilitates stain penetration into fat droplets. Place a cover slip over the stained sample and examine under microscope. And here we see the presence of large red-orange refractal globules, neutral fat, which indicate triglycerides not digested. If the stool contains undigested triglycerides, it suggests a problem with digestion. This usually means that the fats were not adequately broken down into free fatty acids and monoglycerides, possibly due to pancreatic insufficiency, lack of lipase enzyme, or bile acid deficiency, from liver or gallbladder issues. In this case, the possible conditions: pancreatic insufficiency, gallbladder disease, or liver disease. The indirect method follows the same steps as the direct method, with one additional step. Add 2 to 3 drops of 36% glacial acetic acid. The glacial acetic acid clears background debris to improve contrast and facilitates the release of fatty acids from saponified fats, thereby enhancing detection. Then heat until bubbling appears. After that, examine the sample under a microscope. You can see here the presence of free fatty acids and monoglycerides, which are the products of triglyceride digestion. These are typically present when triglycerides have been partially or completely broken down, but not properly absorbed. This is an indication of malabsorption. This suggests that while fats have been partially digested, the intestinal absorption process is impaired. This may be indicative of intestinal disorders such as celiac disease, Crohn's disease, or short bowel syndrome. The second test is the D-xylose test, which measures the level of D-xylose in blood or urine samples. It is used to help diagnose conditions that impair nutrient absorption in the upper small intestine, such as mucosal damage seen in celiac disease or other malabsorption syndromes. As you can see here, the small intestine can be studied in 2 parts: the upper small intestine, duodenum and jejunum, and the lower small intestine, ileum. Vitamin B12 absorption is the best test for the lower small bowel. In contrast, D-xylose absorption test is considered the best test for the upper small intestinal function. Why? Vitamin B12 is chosen as a diagnostic marker for lower intestinal health because its absorption occurs exclusively in the terminal ileum and depends on intrinsic factor, a glycoprotein secreted by gastric parietal cells. Impaired absorption of vitamin B12 can indicate conditions affecting the terminal ileum, such as Crohn's disease, surgical resection, inflammation, or pernicious anemia. Therefore, assessing vitamin B12 levels can help detect malabsorption syndromes and ileal dysfunction. In contrast, D-xylose is a monosaccharide simple sugar that is absorbed in the proximal small intestine, mainly in the jejunum, without the need for digestive enzymes or bile. Its absorption depends solely on an intact intestinal mucosa. Therefore, the D-xylose absorption test is useful for assessing mucosal function. If there is damage to the mucosa, such as in conditions like celiac disease or tropical sprue, D-xylose absorption will be impaired. As you can see in this figure showing the inside of the small intestine, in a healthy person, nutrients are absorbed by the villi and pass into the bloodstream. In contrast, in a person with celiac disease, these villi are damaged by inflammation and become flattened, reducing the surface area for absorption. As a result, fewer nutrients, including simple sugars like D-xylose, are absorbed into the bloodstream. D-xylose test also can differentiate the cause of steatorrhea. Either it is due to the malabsorption or due to the pancreatitis. How? In intestinal malabsorption, the intestinal mucosa is damaged, resulting in impaired absorption of D-xylose. As a result, D-xylose levels in blood and urine will be low. In contrast, in pancreatic insufficiency, the mucosa remains intact, allowing normal absorption of D-xylose, even though other nutrients, particularly fats, are poorly digested due to a lack of pancreatic enzymes. Therefore, D-xylose levels in blood and urine remain normal. Both conditions result in fat malabsorption, but for different reasons. How the test is performed. First step is patient preparation for the test. 1. Fasting. Adults must fast for at least 8 hours prior to the test. And children under 9 years should be fasting for 4 hours before the test. 2. Dietary restrictions, 24 hours before the test. Patients should avoid foods high in pentose sugars such as jam, jelly, pastries, and fruits. 3. Medication precautions. Certain medications may interfere with test results including aspirin, metformin, D-xylose, opium alkaloids, and atropine. The healthcare provider may advise temporary discontinuation of these medications before the test. After the complete fasting period, the first step is initial sample collection. A baseline blood sample will be taken before ingestion of the D-xylose solution. The baseline sample reflects the patient's normal blood sugar and D-xylose levels under fasting conditions. It serves as a reference point for interpreting later blood test results taken after D-xylose is ingested. 2. D-xylose solution intake. Just prior to administering xylose, patients should empty bladder then. You will be given a measured dose of D-xylose solution to drink. Adults, 25 g xylose in 250 milliliters water orally. Children, 0.5 g per kg xylose in water orally, maximum 25 grams. 3. Collect urine into a dark bottle for 5 hours starting with ingestion of xylose. The container must contain a preservative, such as thymol or toluene, to prevent sugar breakdown by bacteria. Store the container as instructed, usually in a cool place or refrigerated if required. 4. A second blood sample will be collected 2 hours after drinking the solution for adults into sodium fluoride tube, and 1 hour after drinking the solution for children. A third blood sample may be collected at the 5-hour mark. The 5-hour blood sample is not always required, but some clinicians or labs include it for a more thorough evaluation, especially if urine collection is difficult or incomplete. Note: for adult patients who cannot tolerate the standard 25 g D-xylose dose, a reduced 5 g dose in 250 milliliters of water may be used. Patient height and weight must be documented to adjust the dose and interpret results accurately. 2 blood samples are collected, 1 fasting sample before ingestion, and another at 1 hour post-ingestion of D-xylose. Urine is collected over 5 hours starting at the time of ingestion, following the previously mentioned collection procedure. The final step of the D-xylose absorption test is the analytical method used to measure D-xylose concentration in blood or urine samples. This method varies depending on the laboratory protocol and the test kit manufacturer, and may include one of the following techniques. 1. Colorimetric assay. 2. Enzymatic method. 3. Or spectrophotometry. What normal results mean? A normal result depends on how much D-xylose is given. A positive result means that D-xylose is found in the blood or urine, and is therefore being absorbed by the intestines. And what abnormal results mean? Lower than normal values may be seen in celiac disease, Crohn's disease, a lymphatic obstruction, small intestinal bacterial overgrowth, and viral gastroenteritis. Thanks for watching. If you enjoyed the content, don't forget to subscribe to Deep Microbiology channel and turn on notifications to stay updated.